Dear pure urologists, good evening one and all. Today topic is laparoscopic instruments and instrumentation. Basically, most of the urologists are doing now nephrectomy, pyeloplasty, ureteric reimplantation, VVF repair. After that, partial nephrectomy, radical nephrectomy, and prostatectomy, adrenalectomy, also laparoscopically. Everybody initially in the private practice start with basic instruments like Maryland, Grasper, Caesars. But that is not the only thing we look at it. If you want to be safe during the surgery, right from the insufflator, the cannula, open method, retractors, everything need a separate set which are not very costly apart from the monitor. To discuss about that today, actually, the faculty is actually an eminent urologist from the Nadiad. To be honest, for his knowledge and caliber, this topic is a small topic, but we have seen last 20 years passionate about teaching basics also in laparoscopy, and he is the one who worked on suturing for years to teach the youngsters. Robotics or laparoscopy may be different, but as of now, 80% of the Indians do laparoscopy, and ergonomics and suturing is a very important part. Chicken model, where two anastomosis were primarily designed by Dr. Arvind Ganpule. So I will introduce sir. It may be a long introduction, but it is worth for the youngsters how a career can be molded with sincerity. So with this, I will share my screen. And today topic is laparoscopic instrumentation. So Dr. Arvind Ganpule is the Vice Chairman Urology, Chief Division of Laparoscopy and Robotic Surgery, MPUH. Instead of Muljubai Patel, I am reading MPUH because Nadiad itself, Nadiad means kidney hospital means MPUH, it's like that. We have all learnt laparoscopy, suturing and RIRS from Nadiad after our MCH. So that is one of the good academic centers in India. There he is the vice chairman. Now, he has 203 PubMed publication to his credit in reputed peer-reviewed journals and 23 book chapters, edited 6 books. He is proctor for intuitive surgical inclusive and performed over 900 robotic procedures independently on this platform, which includes 43 robotic renal recipient transplant. He is founder council member of Robotic Urology Forum and currently serves as treasurer of Robotic Urology Forum. He has co-authored 3 important urological reference book chapters. One is Campbell Urology, which is the Bhagavad Gita of Urology, edition 13th, chapter 95 on lower urinary tract calculi. Recently it is published. Hinman's Atlas of Urology, 8th edition. Smith Textbook of Endourology, chapter Imaging in Access, Percutaneous Renal Access under Ultrasound Control, 3rd edition. He has 2 patents granted by the Indian Patent Office. One filed the patent with IPO, patent number so and so, laparoscopic needle holder. We also have this Ganpule needle holder, which has a narrow tip at the end so that the precision is increased, like in urethroplasty. Intrarenal pressure regulating system, that is related to the RIRS or any PCNL. He is currently the associate editor for the Indian Journal of Urology and the editorial board of World Journal of Urology. He is currently the council member of the Urology Society of India. He is empaneled faculty for the National Board of Examination, New Delhi. So current select awards are Best National Reviewer, Indian Journal of Urology 2012, Best Reviewer, Endourology Society 2013, 15, 16 for 3 years, Outstanding Alumnus Award 2015 by Dr. D.Y. Patil University, Kolhapur, which is his alumni. With this introduction, I thank Ganpule sir for taking this task. I already mentioned that these are basic topics. He is very knowledgeable in many respects, but we will stick on to the laparoscopic instruments today. Thank you, sir. Over to you.
Thank you very much, Dr. Chandramohan. Indeed, it is an honor to be on this platform. I have been once or twice on this platform, and I see the popularity this platform has, which actually echoes your own popularity in the arena of teaching in urology. I'm really proud of proud to be associated with you as a friend and as well as a colleague. With these short few words, I would like to set the ball rolling. I'll make it full screen. Yeah.
Yes, sir. You are visible and you are audible, sir, clearly.
Thank you. Thank you. So I have divided this talk into actually two sections. So the first section is for hand instruments, and the second section is for imaging equipments, because I always feel that not just hand instruments are important, but the imaging equipments are also important. Going a bit further, if I would like to divide how I have divided with the flow of my talk, is that I have divided them as instruments used for gaining access, instruments used for dissection, instruments used for hemostasis, and then finally the imaging, light sources, monitors, etc., etc. We'll talk something about that before we conclude after maybe 40 to 45 minutes. So we will start with the first subsection, that is instruments that are used for access. And I believe that most of us who are here are either urologists who are in their first 5 to 10 years of their careers, or residents in training. And I'll go into a bit basics. Maybe it may be a bit boring for an experienced urologist, but for others it will be of much benefit. So the whole presentation will be pictorial, and I'll try to bring out as many points as possible. So first we'll talk about the Varus needle. So as we are talking about the instruments that are used for gaining access, Varus needle, if you're going to have an closed access, this is the first instrument that you have to use. They are again broadly divided into two parts. One is disposable, and the second one is the non-disposable or the reusable. So reusable ones, they are manufactured by many of Indian makes, RK. Then we have got many. I'll not name them, but the basic difference between reusable and the disposable ones are that in the reusable, you'll not see the safety specifications. Like you'll not see the hanging ball, you'll not see the indicator, you will see the hole, but you will not see the hub in this particular way, which is transparent. So all these things add to the safety of this particular instrument. But as far as we are when we consider the disposable variety, there are two major players in this. One is auto suture and ethicon, and out of that, ethicon is the most common one that is sold and which is the most popular one. And there is a reason behind that as well. So going a little bit into the procedure type, whenever you are going to use the Varus needle, point number one is that you have to use it as you have to hold it like a dart. The thinner eminence should be preventing the extrapolating of the Varus needle into the abdomen. You have to follow the four important steps. Four important steps. The first is that aspiration. You should not see any red, brown, or green whenever you are going to aspirate. The hanging drop test should be positive. The indicator, which actually is marked with the arrow here, if you are in the proper position, the ethicon needle will always show a green indicator. If you are in the preperitoneal space, it will be red, otherwise it will be always green. So these safety specifications you will never see in reusable ones. And I feel that that is the biggest problem. The hub is not transparent in reusable ones. We'll go into a bit detail of this thing. If you go into the detail of this thing, you'll see that if you come to the tip, you will see that the tip has got a gas vent, and the gas vent is always directed lateral to that of the bevel. It is never directed towards the bevel. You imagine that if the gas vent is directed towards the bevel, even though if you are in the proper position, the insufflator will show as if you are not in the proper position, because the gas will go and hit the bevel. So why am I bringing out this point? Somebody might say that I'm just wasting time on unnecessary things, but this is very important because we all Indians are very cost conscious, and we tend to use instruments which actually are not intended to be reused. So if you want to reuse this, I'm nothing against reuse, but if you want to reuse the instrument, always make sure that the vent is laterally directed. Sometimes what happens, if you are going to reuse it, it is directed medially. You should always make sure it is directed laterally. Always see that the tip indicator is working, and always see that the hanging ball is always moving. If the hanging ball is not moving, it might give fallacious results for that. There are a few variations in the Varus needle about the reusable ones, sorry, the disposable ones. And this is one of the variation, which is called as the mini port. The mini port is basically a port, which is a 2 mm port, and the cannula of the port would serve as a small port. The outer hollow sheath, it serves as a small port through which it can be used for inserting double J stents. If you have gotten 2 mm instrument for retraction, you can also use the same for retracting the instrument, particularly when you are lifting up the uretrogonadal packet. And most important, this particular cannula has got a Varus needle which can be passed all the way through it. So one instrument and two uses. But nowadays, I believe that because of the cost, it is not much popular. But I feel that it is a very versatile instrument. Now, as we are talking about the instruments that are used for access, this is something very important, which has got an historical importance nowadays. But in the old days, Dr. Chandramohan will remember that when in 2005, 2006, people started doing laparoscopy, when one was going to gain an retroperitoneal access or maybe an open access, they used to use the balloon tipped Hassan. And this was the original version. This I have taken from a book, and this is the actual picture. But the book you show that it was a very bulky instrument, but it has got its own indications, and the indications are that it is used particularly when you are having an hostile abdomen, multiple scars, whenever you are going to gain access in pediatric cases, very small children. I personally prefer to take an access which is an open access whenever I want to create new opportunity in children, because I'm not very confident that my varus needle will be in the exact position. So I give an umbilical skin crescension and place the port. So in those instances, these ports are very important and useful both. Why? Because the balloon and the cuff, these both will help in keeping the port in the proper position, and the port will not extrude itself from the abdomen, and pneumoperitoneal pressure will be maintained. There are, I do agree that these are fancy devices, but you see the way in which the balloon and the cuff will help in maintaining the ports in the proper position. As we are talking about the ports and access devices, we go to our next instrument, and those are the ports. Again, classification, as we are in a class wherein we need to understand the different classifications of the trocar. So broadly speaking, again, reusable and disposable. One more classification is based on the size. It may be 15 slash, sorry, 12 slash 15, or it might be 5 millimeter trocar. It might be, like you can see here, it is a dilating tip, or it can be an cutting trocar. I'll let you know what I mean by cutting trocar. So if you go a little bit into this thing, I was talking about the dilating tip trocar, and this is marketed by Ethicon by the name Endopath OptiView. And why it is called as Endopath OptiView? Because you can insert a telescope through the hub of the trocar, and the telescope can go all the way through the shaft right up to the tip, and it is a dilating tip trocar. So the surgeon who is not very confident whether his instrument is there inside the abdomen, preperitoneal space, he can insert the telescope the trocar with the telescope inserted inside under vision, and see the telescope entering through the skin, subcutaneous tissue, peritoneum till it enters into the peritoneum. So a safety feature. But this thing would not happen when you are using a cutting tip trocar, because you can imagine what I showed initially was you have got a transparent tip here. But here you don't have a transparent tip, you have got a cutting tip. So what happens that whenever the trocar goes and hits a hard blade, a hard surface, the blade juts out, and the blade actually cuts the tissue, facilitating the entry of the trocar into the peritoneum. So it all depends on what you are used to. But whichever trocar you use, the anatomy of the trocar is the same. And the anatomy as follows: as you have got the obturator, you take disposable or reusable one, you have got a obturator, and then you have got a cannula, which is again classified into a shaft and a housing. And very important, again, it's a common feature. The housing has got a vent, and the housing also has got a valve. If you are using disposable trocars, then the valve are typically flap valves. But if you are going to use reusable trocars, they are typically trumpet valves. But if you are going to use uh, disposable ones, it's a flap valve. Both have got the plus and minus. Before I go to the next slide, this is one more important feature, which is called as the reducer. So all of you know that why reducers are used, because suppose you want to introduce a 5 millimeter instrument through a 12 millimeter trocar. You don't use a reducer, you are going to lose pneumoperitoneum. So having a reducer is very important. Coming to the walls, we are talking about the walls. So whenever you are going to use a trumpet wall, that is an reusable trocars, you will have trumpet walls. So whenever you are going to insert needles through a trumpet wall, the trumpet wall should always be armed, that it should be always pressed below, otherwise the needle will break inside the trocar. That's not the case whenever you are going to use the reusable trocars, wherein there you are having the flap walls. I would say that this is a very important slide, not the most important slide, but a very important slide, because it indicates that whenever you are, suppose you are going to do a radical cystectomy, You are not going to use a 2 millimeter trocar. You are going to use a 12 millimeter slash and 15 millimeter port. So you have to understand that a given port will accommodate which instrument. Now you see here that a 10 millimeter port would accommodate a 10 millimeter telescope, a 10 millimeter clip applier, which is a violet color code. It will use you can use a right angle as well as the endocatch one, the Ethicon one, the endocatch one. But if you want to use the Satinsky, you want to use a larger endocatch bag, 10 millimeter will not work. And if you are working in a very cost sensitive program, then you are going to waste a trocar. So always make sure that which instrument will go through which trocar. We come to the telescopes, the laparoscopic telescopes that we use. Now, most important, I always find this very interesting. This is I've taken from a catalog, but you see that here they have written that the telescopes are autoclavable. Now, I don't know that who has got the courage to autoclave a telescope, but actually speaking, they are autoclavable. Coming to the color coding of the telescopes is the same as that of an cystoscope. So 30 degrees like red, 0 is green. Again, the rule or the dictum is that whenever you are going to do an renal surgery, always you are going to use an 30 degree. And whenever you are going to use do an pelvic surgery, it will interchange between 0 and 30 based on the habitus, how the pelvis is. But whenever you are going to use and do an kidney surgery, you want to see behind the artery and vein, you will always use an 30-degree telescope. We come to part 2 of section 1, that is instruments that are used for retraction and dissection. So many of you will be surprised when I show this picture, but actually this picture is actually the same as this picture, as you can see in cursor, but my cursor moving over this picture. So whenever a staff nurse gives this instrument to a resident in urology, he has to realize that actually this instrument is a 3-part instrument. It's not a single part instrument. And as a resident or a trainee, you should always learn how to assemble and disassemble these instruments, which can double up as retractors. They can double up as in retracting instruments. But point is that many times while you are doing an surgery, the inner tube gets disengaged from the handle and it doesn't work, and you are at a critical step. So you should have the troubleshooting capabilities wherein you know how to unlock it and how to again place the inner tube properly through the outer tube to the handle. So basically all of these are 3-part instruments. A little bit more specifics about this is that whenever you are seeing the handle of these instruments, there are these 3 types of handles that are available. Obviously this is non-locking and these other 2 are locking. So what happens that the non-locking ones are used particularly when you want to do an temporary grasp or you want to retract something, like you want to retract the bowel, you are going to use non-locking. But if you want to retract the liver, you want to retract the spleen, you want to make sure that the instrument holds the liver properly in place with the help of the Alice, then in those instances either use lock with a ratchet or you can use this Manhes type of ratchet. So basically you need an locking whenever you want to retract the liver, because that is one way in which you can retract the liver. Again, always have a look on the jaws of these instruments, the retracting instruments. Whenever you want to retract something, it should be double action. Whenever you want to grasp something, it should always be single action, because one jaw will be steady while the other will grasp it. So in that way, always make sure that if you want to do like it's a very big kidney, you want to lift up the kidney, you want to have a double action grasp. You want to grasp something, always it should be single action. Very important instrument is this scissor. Again, broadly speaking, I'll not always say it's reusable and disposable, but what is more important is the jaws of the scissor. Short jaws always it's used for dissection. Short jaws are always used for cutting suture. Long jaws, particularly when you want to do a fast job. If you want to do an partial nephrectomy under an mom ischemia, always it's a long jaw. If you want to do a long jaw, straight scissors, it's always used whenever you're doing a donor nephrectomy, because you want to have a clean cut on the artery and the cut should be fast. So based on what are your uses, what you are going to use for, you have to select the type of jaw. But what is more important is you have to realize that where do we use the scissors most commonly is, I feel that for spatulation whenever you are going to do an pyeloplasty. So digressing a little bit, if you want to do an right-sided pyeloplasty, it's always easier because you are going to do the spatulation with your right hand. and everybody is not very ambidextrous or versatile or facile. So a left-sided pyeloplasty, the spatulation is sometimes very difficult because you have to spatulate it with your left hand. So that is the importance wherein you sometimes you can use these reticulating scissors. So if you are not ambidextrous, then you will have to dissect the ureter, bring it in alignment with the port and do the spatulation. Otherwise, you can use this reticular scissor wherein you can easily do the spatulation. Now, those who have come to MPOH or seen anybody of us operating, you will see that we very frequently use the suction because we feel suction cannula does the same job as a cannula of as an open in open surgery the finger does the job, because that helps the surgeon to get into the proper plane and then dissect the proper plane. So broadly speaking, these are the two varieties of suction cannulas that are available. One is the reusable ones. They are very sturdy, very effective. They have got one knob for irrigation and one for suction. The same thing can be done with this battery operated suction, which are obviously one time very costly. But this particular apparatus has got its own battery. So they are very powerful. You can modulate the amount of suction that is there, modulate the amount of irrigation that you want to use. But again, cost is a big consideration, this thing. And you will always hear this thing whenever we are discussing instruments, that cost is a big consideration. We come to part 3 of section 1, that is the different methods that are used for hemostasis. So we'll go first we'll talk about clips, then we'll talk about staplers. I just when I was just having a prelude talk with Dr. Chandramohan, I realized that I've not mentioned anything about bulldogs, but I'll try to cover it up, cover the bulldogs when I'm going to discuss it, and then finally we'll talk about the energy sources. So these are the clips which are called as the titanium clips, and I would say that these are the most insecure clips. These are not the interlocking clips, but these are non-interlocking clips. What are the uses? Whenever you want to temporarily arrest some muscular bleeder, some bleeder on the girotas, temporarily arresting the bleeding, these are useful. They are very low cost, very cheap, around 40 to 50 rupees. Not secure, available in a cartridge of 6, and they can be easily unclipped. So these are the 4 parameters that always one takes into consideration whenever one is evaluating the different types of clips. So these are the most commonly used clips, which are called as the interlocking clips. They were initially marketed by the name Allport, then they were marketed by the name Liga clip. But the name apart, what is more important that they come as preloaded applicator with 20 clips. They are very secure. They cannot be easily unclipped. They are costly. Let me tell you that one assembly will cost you something between 18,000 rupees. So this is what everybody has to discuss with the instrument manufacturers. Like 18,000 rupees, somebody will do an open nephrectomy. Somebody also might do a lap nephrectomy in 18,000 rupees. So how does it make sense by just marketing having an MRP of 18,000 rupees? But let me tell you that these are very secure. I know that they are also used in donor nephrectomies whenever you are going to secure the adrenal, whenever you are going to secure the lumbar. They are radio opaque as well. What is the beauty of these clips? As these clips actually you don't have to remove the applicator. You have to keep the applicator in position, and serially you can just go on deploying the clips, because the clips will be deployed from this particular hub, and without removing the applicator you can apply them. So they can be used for application on the adrenal vein. They can be used for application on the adrenal on the lumbar vein. Sometimes even on the renal artery also people have used it. So this is how they actually can be used. They can be used for securing the gonadal, the adrenals, as well as for temporary arresting small bleeders as well. Now I would say that these are the most common, most popular, but along with that, they are the most controversial as well. And these are the most commonly used clips, because that's the reason I'm going to spend some time on these. The properties are that they are very secure. They cannot be easily unclipped. They can only be unclipped with 3 ways. One is you have to use the harmonic on the arm or on the shoulder of the clip to unclip it. You can have to use, otherwise you have to use an custom made unclipper, or you can use unclip it with the help of an hemostat, but very difficult to unclip. They are radiolucent, so they will not be seen on X-rays. Costly. As far as the cost is concerned, like if you consider the cost of the applicator, one clip, one application will cost anything. I'm talking about Teleflex. I'm not talking about anything else. The Teleflex It will cost approximately 400 to 450 rupees per clip application. If you consider the cost of the applicator as well, they are available in a cartridge of 6 clips. So what you are seeing right now in the slide is the 10 mm clip or the violet clip. The smaller one is the green clip, that is a 5 millimeter clip. And there is one more clip by the name gold clip, which is used for the renal vein, and that is used for applying or securing the renal vein as well.
One of,
Now, these are,
sir, sorry to disturb you.
yes, yes.
If you have that video, one of the listener said by chance applicator removal or cartridge. If you have, okay. Otherwise, next time whenever.
Okay, I
That's
can
good.
share it with you. Maybe
Yeah.
whenever, yeah.
I will share in pure.
Yes,
Because it's interesting and we feel really annoyed if you have put an important artery, even like inferior mesenteric artery sometimes.
Okay.
We use cartridge, but harmonic, but it burns and breaks it.
Correct.
Be close. But applicator, how much it will cost, sir? Sorry to interrupt.
So when
Applicator to
actually
remove the.
actually we can actually make a deal with Teleflex. Nowadays they are open to deals. But when we got the applicator, we had gotten a deal for 6 applicators together. So that was costing between 75,000 to
Clip
80,000.
remover. I mean to ask clip remover.
75,000 to 80,000 rupees.
That's okay, reasonable. Once time you can buy it. Any clip can be unlocked with this or separate for each size.
So the size will differ. Like 5 mm, there will be a different unclipper.
Uh,
For 10 mm as well as 15 ml, they will be different because we'll have to
got the
engage
point.
that thing into the knob.
Got the point. Please, sir, proceed, sir.
Yes. So now why are we discussing this thing so much? Because everybody needs to understand this one very important thing is that if you go into the instrument manufacturer's recommendation, there is a black box warning as far as these clips are concerned, and they are contraindicated in the use of for securing renal artery in laparoscopic donor nephrectomy. So following this particular, why this black box warning has come? Because there were incidences of 6 deaths, if I'm not mistaken. That's what is written on the FDA site. And because of those 6 deaths in the donors, the instrument manufacturers have recommended that this cannot be used in donors. So after that, there was a study from the Ponsky group. If somebody is very interested, he can go into 2009 Urology Gold. And that particular journal, 2009 Urology Gold, Lee Ponsky, they have done a multi-center study. And therein they have come out with these 5 cardinal rules, wherein they say that if you follow these 5 rules, it's very unlikely that the clips will slip. So rule number 1 is see the knob before applying the clip. Ensure an audible click after application, and everybody in the OR should listen to that click. Ensure circumferential dissection of tubular structure. It may be artery or vein before application of the clip. Keep a cuff of 2 millimeter beyond the last clip that is applied on the patient side. And always apply 2 clips on the patient side. And now there is a caveat to what I said in number 5 is that 2 clips, when they say 2 clips, is 2 hemlock clips. It's not like one metal clip and one hemlock clip, one metal clip below and one hemlock clip above. 2 clips, hemlock clips on the patient side and a cuff. So if you follow these 5 principles, it's very unlikely that any of your artery or vein will slip off. And everybody of you who is doing laparoscopy must have seen this particular thing, that it's very unlikely that clips slip off if you follow these 5 principles.
Is it true that in Western countries this is banned? Some rumor, some controversies come on this because of the, especially donor nephrectomy, they use stapler,
Yes.
which is not commonly used in India. Very few use a stapler. Any
Yes.
comments sir, on that?
Actually the FDA website, if you put in this hemlock clip, laparoscopic donor nephrectomy, you will see that the FDA has issued a black box warning. And that black box warning is very clear that you cannot use these clips in laparoscopic donor nephrectomies. And following this FDA black box warning, the instrument manufacturers have given a disclaimer. If you see the insert package, they will say that these are contraindicated in lap donors. So
Oh,
this particular thing was issued in 2006, but it's still going on. So they use the staplers there.
okay.
So as we are talking about staplers, the next instrument is the stapler. Again, we in our country would be using staplers, particularly when we are doing lap or robotic cystectomies for boil work. But many a times, if you have got a very difficult hilum, and you have dissected the hilum, you have dissected the upper pole and the lower pole, some surgeons will also use staplers for securing the hilum on block or sometimes individually as well. So we need to understand some basics of the stapler. Before I go ahead or tell you the parts, I must tell you that you go to any instrument manufacturer. If you go into any instrument manufacturers, this thing, you will always see that they have recommended that one stapler device can be used only in a single patient. So you cannot use the same single patient, you can use it multiple times. But in the same device, you cannot use in multiple patients. So that is number one. There is one more mnemonic that you have to remember, that in as far as staplers are concerned, the color of the cartridge is very important. So B is for blue and W is for white, is for vascular. So whenever you are going to use a blue cartridge you should always use for bowel work, because B is for bowel, is for blue, and W is for white, is for vessel. So for vascular stapling. So whenever you are going to use it on the vein, it should be white and it should not be blue. So all those horrendous videos that you see, most of the time they are reusing the staplers, or they are not using the proper cartridge. As far as the staplers are concerned, you have got a cartridge, you have got a shaft, and you have got a handle, and the handle has got two knobs. One knob is for application or approximation of the cartridge, and the second is for firing the stapler. A few more important points are that you see that it always has got a articulating hinge, it has got a shaft and an articulating knob. So the articulating knob will move the stapler in this way, whichever way it wants to. And once you press the second knob, you can press the release button, and this release button would actually help you in opening the second knob. A few more important points on the stapler is that whenever you are going to open the insert package, you will see the stapler size and the stapler length. So the stapler length is very important. Suppose you have got to, like here, you can see that the length of the renal vein is very long. So there is no point in using a 30 mm staple length. In those cases, you have to use a 60 mm staple length. Again, a very important point, you have to always see what is the port size that it accommodates. A few staplers you see that, for example, endopath EZ445, that particular stapler will only go to an 18 mm port. So no point in placing a 12 mm port for that. So always see that which port will accommodate which sort of stapler. One more important thing is that you are seeing these rows, 2.5, 3.5, 4.1. It indicates that how many rows the staple fires. So based on which structure you are going to apply it, you are going to decide that how many rows you are going to use it. One more important thing, that whenever you are going to use a stapler, always ask yourself as well as see in the insert package whether the stapler will only staple or it will staple and cut. It's very important. So this is what I was talking about. B is for blue for boil and W for white for vascular. So that is the thing. So we come to the next part, that is the different types of energy devices that are available. So broadly speaking, you have to always understand that whether a given device is in high voltage, low current, low voltage, high current, or it is low voltage, low current. Our aim is that it should be low voltage, low current, because there will be minimal lateral dissipation. So the different devices that are available are monopolar, which includes hook, scissors, shears, or cup; bipolar dissectors, which are high voltage, low current; ultrasonic, or which is available as harmonic; or ligashore, which is low voltage, high current; NCL, which is nanopolar thermostat; or bipolar, which is a plasma kinetic. So broadly speaking, these are the 7 types. Thunderbit is a combination of ultrasound with bipolar. So you can see that these are the 7 varieties of energy devices that are available. We'll just go briefly have an overview of all of them in the talk. But before we go ahead, I think I should just give you a summary of everything. If you consider ultrasonic device, the ultrasonic one, the commonly marketed one, is the harmonic. So the advantage of the harmonic is that it has got minimal lateral dissipation of the current, but you will see that the jaws get heated up. So whenever you are using a harmonic, many times if you are going to use it around the hilum, you have to be very clear because the jaws will remain heated up for quite some time, which is not an issue with Ligashore. So Ligashore is marketed by Covidian. Ligashore has got an it has got an insulation over its Maryland jaws, which would help in preventing lateral dissipation of the current. The monopolar hook is particularly very commonly used as you go along near the hilum, and they are particularly used for fine and precise dissection. Whenever you have got an specimen which is actually related to oncology, it's a good idea always to bag the specimen. So whatever specimens the retrieval bag are there, the commonest problem with this bag is the cost. These are very efficient, very unlikely that these bags will rupture. But the cost is a problem. Again, it will range anything between 25 to 30,000 rupees. So everybody of us, everybody who is listening to this webinar must have done some modification of such bags. But what is more important that you use whichever bag you want to, but always make sure that there is some mechanism in which the mouth of the bag remains open. So the mouth can be kept open by creating a tunnel over here and passing a ureteric catheter through it on both the sides, which will help the tautness of that particular ureteric catheter will help in keeping the bag open and entrapping the specimen. Once the specimen is entrapped, you can just remove the ureteric catheter. All ports which are more than 10 millimeter in size, you should make it a point that all these ports are closed. So if it is a very thin child, maybe you can use a GU46 needle and you can close it. However, if it is a thick abdomen, I'm sure that if it is a very thick abdomen, it's very difficult to actually go up to the fascia and close it with the help of the GU46. In those instances, either you can use a Carter Thompson needle or a Bursey facial closure needle. But it's a must that any port which is more than 10 millimeter, it should always be closed. We come to section
Is it
2 of
necessary? Sorry, sir. Is it
yes, yes.
necessary if you go through the rectus sheath which has anterior and posterior above the umbilicus? If you go little obliquely towards the pelvis or towards the renal area, majority of times, if you go obliquely, the chances of hernia are less. But is it mandatory to close, especially in obese patients?
I would not go into those terms of mandatory, but I would say that if it is possible, try to close all the ports if they are more than 10 millimeter in size.
Okay.
Sometimes I do agree what you are saying. There is a point in that sometimes in obese patients, actually where it is required, it's sometimes very difficult just because of the thickness of the abdominal wall.
Yes, sir.
And I do agree that when you are above the umbilicus, many times you can just avoid it. But whenever it is easy and you can do it easily, it's always a good idea to close it. So we go to our next section, that is imaging. So just if we want to give a theoretical definition of what is an imaging system. So an imaging system is a chain of equipments that are linked together in place to perfectly produce an excellent laparoscopic image. As it is said very famously that in the good old days, how an patient used to decide that whether a surgeon is good or bad. He used to decide that based on how the scar looks like. If the scar is good, then the surgeon is good, regardless of whatever function it is. But nowadays, a surgeon is good if the surgeon can see better. So naturally, that brings me to the point that if you have got a good imaging equipment, then naturally the results of the surgery are going to be good. So again, it's famously said that if you want, you don't compromise on two things whenever you want to buy anything in laparoscopy. One is hemostat instruments used for hemostasis, and the second one that are used for imaging. So the imaging equipments are like the Magnificent Seven, the famous movie that we saw during our good old days. And the Magnificent Seven, as far as the imaging equipment go, are as follows. Those include the light source, that includes the light cable, it includes the laparoscope, it includes the laparoscopic camera unit, video signal processor, and finally the video cable. So all these seven, that is the video monitor include together the Magnificent Seven. So we'll discuss all these seven shortly so that we can understand how we can decide which one we are going to use. So it's a fine balance between these seven, and we have to learn to how to maintain the balance in them. So let's first start with the light source. So the quality of image depends on the quantity of light available at each step. And a typical light source has got these four components, and that includes the lamp. The lamp is always heated, so always there is a heat filter, and then the lamp and the light is further condensed with the help of the lens, and through the shutter it is emanated. So these are the four components of the light source. But what is more important is we'll go into the details of the lamp, then heat filter, and then everything else. So in good old days, maybe before 2000, everybody was using the halogen, that is 150 watt lamp. But nowadays, everybody is using the LED light, because it depends on the light emanate, the quality of light emanated, as well as the temperature. So you can see the temperature of a candle light, clear blue sky, and what is the overall picture whenever you are using a xenon bulb or you are using an LED bulb. So the halogen bulb was used initially, and it used to emanate an yellow light. The electrodes were made of tungsten filament. The average life was 200 hours. In practice, the yellow light of the halogen bulb is compensated in the video camera by white balancing. So it really did not make any difference. But actually, there was a big problem with it, that the average life was very less as compared to the LED light, and it used to generate a lot of heat. So that was the major drawback of using halogen bulbs. So then came the xenon light source, and the xenon had slightly bluish tint, but it was more natural. And this is the typical equipment you will see on the trolley. The xenon emits a spectral temperature of approximately 6000 Kelvin with an average power of 300 watt. And you remember the halogen, it was just 150 watt. But again, see the major difference. The halogen was just 200 hours. Here it is increased to 500 hours. So it becomes more cost effective, more economical. The image that you see, the light emanated is better. So that is the reason that they came into picture. So as I mentioned, they were extremely economical. These LED lights, further to the xenon ones, we are going to the LED one. Extremely economical, long life. Imagine 200 hours, 500 hours. Now we have got 30,000 hours. Ultra low maintenance, high energy efficacy, ready to use. Just it's plug and play, environment friendly. So nowadays you'll see that many times, many of the operating room theaters will be using the LED lights. We come to the next component of this thing is the light source. 100% energy is consumed, and most important thing, as you can see in the picture, you have to be very careful when you are using this particular thing, that it tends to burn and create a hole on the skin of the patient as well. So you have to be careful about it. A few important thing is that it will come the controller or the shutter, the last component of the thing that we are talking about, the shutter. It can be either automatically adjusted or it can be manually adjusted. We come to the next part of the Magnificent 7 is the light cable. There are of two types. One is fiber optic cable or the liquid crystal gel cable. Commonly used are the fiber optic cables. We all have seen this diagram, which is there in the famous book of Moormeyer, which reflects or depicts the principle of total internal reflection. And that is very important whenever you have to understand whenever you are going to use a fiber optic cable, because we all have got that thing that whenever you see it against the light, you will see a few broken fibers which appear as black. If they go beyond certain thing, then definitely the light emanated is going to go down. And for preventing this particular problem, although it will not be completely prevented, there are a few important things that you have to remember is that avoid twisting these cables. The curvature radius of the light cable while storing should not be less than 15 centimeter. The end of the cable should be periodically cleaned. The distal end of the fiber optic cable should never be placed on or under drapes, as I just mentioned that they tend to cause burns or ignite drapes. Never hold it against the eye of somebody, because they tend to cause an retinal damage as well. Going to the next one is the laparoscope. We briefly discussed about the laparoscope, the old traditional one, self-explanatory over here in picture, and the routinely used Hopkins rod-like system. Nowadays, we have got the digital laparoscope, excellent vision, chip at the tip of the laparoscope, and nowadays most of the hospitals will be using this. A few important tips are that the 10 centimeter away from the target should be the distance that you have to keep whenever you are using a 10 millimeter telescope to have an optimum vision. 5 millimeter away from the target whenever you are using a 5 millimeter telescope. Average distance should be approximately 5 millimeter. And always you have to do an white balance and the focusing before you start doing the surgery. We come to the second last component, that is the video signal processor. And this is also called as the CCU, that is the camera control unit. It provides power to the camera, processes signals from the camera to the monitor, and it has its most important function. It helps in white balancing the camera. So when you are going to white balance, you also require one more cable that is called the digital or the analog cable. So just to understand what the cables are, it's a very busy slide, but analog is on this slide, on this side, while the digital ones which we use nowadays, that is the DVI, SDI, the HDMI, all are on this side. So the old RGB ones, you remember those three, red, green, and blue, and then you have got three slots behind for the red, green, and blue. They are all variety of analog. While in digital, you'll have those special slots which are there in the posterior aspect of the equipment, like here. If you are going to use the RGB one, that is the analog, you always see whenever you are going to go whether in what way the adapters need to be inserted. Like here are the RGB ones. These are the old VHS inputs. Nowadays, you will not see these. And these are the DVI and the SD output adapters that you see behind. And this is the HDMI one. So the image on the monitor is similar to the old age adage. All the patient sees in open surgery is the incision, but all what the surgeon sees nowadays is the image. So a better image is always very, very useful. So finally, we come to the last part, that is the monitor. Ideally, it should be the medical monitors, which can be either analog or the digital ones. So the medical grade monitors can handle three types of inputs. They can be either composite, Y or C, or it can be RGB. It all depends on the number of lines that are there. You go to any TV shop, you'll see that they have written so much by so much. So what they are talking about is the pixel. That's what I'm going to show over here. So in medical monitors, as I just mentioned, they can be analog or digital. Nowadays, everybody is using digital. You have to see over here. If you are using 8K, you see the amount of resolution that it is going to give. 8192 into 4320. As against in 2K, it is just 2048 into 1080. But something is very important, that whenever you are going to use an 4K, I'm sure that Dr. Chandramohan will have some
Yes,
inputs
sir.
on this, that whenever you are going to use a 4K or say a 52-inch monitor, it's very important that the monitor should not be kept very close to your eye. What should be the distance that the monitor should be kept so that you don't have the pixelization? It should be 5 into the diagonal diameter of the monitor. Say it is 52-inch. So 52 into 5. So those many inches should be the distance of the monitor from your macula, in order to make the maximum of the resolution of the equipment. Finally, a word on white balancing. White balancing is adjusting the primary color to make it pure, natural, and the natural color is white. You have to remember that the natural color always is white. So white balancing is a way of teaching the camera to visualize the color in a proper way. In other words, you have to just tell the camera white is white so that it interprets the other colors in the way you want it to interpret. Always make sure that the white balance is necessary in all the cases every time before starting the surgery. This is absolutely essential. Lastly, with this last slide, I would like to tell you that in this today's era of social media, and it's a very fast connected world with each other, it's very important that you have to have proper video capture devices, because teaching is learning. That's what even Dr. Chandramohan has taught all of us, that actually if you teach somebody, you learn somebody. And when can you teach somebody? When you have got proper documentation. So you may be working in a small hospital, you may be a resident, you may be working in a corporate hospital. You should have proper video capture devices. And this is an slide or an algorithm which shows you the different types of video capture devices that are available. In the old days, we were using the stored JPG images, bitmap images that were available on the floppies. Then we have got portable card media flashes. We have got those thumb drives. They came later on, but you have got floppies at that time. They were less used. Then you have got USB outputs. But nowadays, all the modern systems have got DVD recording devices, wherein you can actually store all your surgeries without consuming your space in cloud. That is called as the network destination, wherein your hospital computer network actually through the HIMS, EMRs, or PACS can actually store all your surgeries on the cloud. So whatever may be the equipment that you are going to use, it's absolutely essential that you have proper video capture devices with you. So I conclude my talk with these few take-home points, that see one, do one should be the goal. whenever you are going to use an equipment, you are not very sure. You should always make sure that you have got a mentor or proctor to tell you something as to which equipment you should buy, how you should buy it. And I feel that aspect of cost is a matter of perception. Today, if something is very costly, you have to see the value in that particular thing before you are going to buy or use that particular thing. So I stop my sharing here. Again, I would like to thank Dr. Chandramohan for this opportunity and allowing me to deliver this basic talk, which I'm sure would be useful to everybody. Thank you so much.
Thank you, sir. So it is an exhaustive and very precise 55 minutes talk. To my fortune, 210 people have attended this session. See, in conferences, good, highly well-conducted conferences will have 300 to 400. But at a time, by sitting at your house cell phone, 200, all my consultants who are at Preeti Hospital have watched. Some of the technicians I told to watch. So if the content is not unethical, if the content is highly informative and it improves the knowledge of so many people online, I feel that it is a honor Arvind Ganpule sir has given. I also mentioned that in every subject he has so much depth of knowledge. Really appreciated that the way Mahesh Desai sir and Sabnis sir have created the environment of teaching. Selfless teaching whenever somebody asks if you have time. If you prepare, they prepare very well and do selflessly. And this session, not only in that way, in another 100 years, as long as YouTube is there, if any PG wants to prepare, he can get the raw material first. He can build upon the new PPT based on these slides. So with this, I must tell that I must congratulate. This is one of the good session where everything is covered in nutshell. Many people have joined, sir, today after a long time, because sometimes it's a dry topic only, but they wanted to do it. Now era has come, everybody has to do laparoscopy. Urolithotomy also they have to do. Juniors are also trying. At least before opening, they are trying. They will have wrong instrument, they will have monopolar cartridge touching here and there. So they will be really benefited. I am very happy, sir, today.
Yeah,
Thank you.
I think Dr. Chandramohan, you can just put an word here that if somebody wants to ask anything and follow up question on this, you
Yeah.
and me, both of us will be more
Yes,
than
yes,
happy
yes.
to answer these
Great.
questions. There is no
We
problem.
will continue this YouTube discussion below. I think maybe we have some videos on how to unlock and restitch. Okay. Thank you very much for the nice presentation. Excellent presentation. Okay, sir. We will keep it like that way, that if any questions arises, both of us will answer in the YouTube link below.
Yes, sure. Okay. Thank you
Thank
so
you.
much, Dr.
Great, sir.
Chandramohan.